Okay, hi everybody. I hope you can hear me. Maybe if somebody from Hines or online can tell us in the chat if you can hear us. Okay, thank you, Matt. I'm Elycia. This is Sarah. We're both PGY4 ENT residents. And we're going to talk to you guys about some things that we think are good to know. All right, so here's the outline of what we're going to be talking about today, just some kind of high yield stuff that is important for you guys to understand in the context of calling us and talking to us about these things. So first we have just a little brief anatomy. So here is the airway up on top. I think maybe you can see my.
No, yeah.
We have the hyoid bone up here superiorly. This is the thyrohyoid membrane. This entire thing is the thyroid cartilage, which inside here is the majority of the laryngeal structures. And then the cricothyroid membrane here between the cricoid and the thyroid cartilage. And then we have the trachea. So first we're talking about trachs. So just a little kind of quick differentiation between a cricothyroidotomy and a trach. So a cricothyroidotomy goes right here in this small soft space that you can maybe feel on yourself. And then a trach goes below the cricoid cartilage, usually between the first and second or second and third tracheal rings. We'll talk about open versus percutaneous, and also awake is a separate thing too.
Yeah, and just to orient you, that thyroid notch, that's your Adam's apple. So,
right
you
here.
know, more prominently, you know, seen in males, but just to sort of orient you like where things would go if you were to look at like cervix anatomy.
Okay, so if you were to do a cric, generally this is only in like an emergent situation, or if there's unfavorable tracheal anatomy or lower neck anatomy. It is really risky. Like I said, the vocal cords are pretty much resting right here. So you're really close to the cords. You're right below the cords in the subglottis. And the problem is with doing a cric, you risk that the patient may be dependent on this airway for life because of swelling in the subglottis. Relative contraindications, yeah, you shouldn't do this in a child. You shouldn't do it in infection. It really just kind of shouldn't be done unless it's an emergency.
Yeah, it's gonna like, if they're gonna, you know, you do it if they're gonna die.
Yeah,
it's like basically, and you can't do a, you know, a slash trach.
We had one patient that had a really high riding innominate. So her innominate artery was like right here coming all the way up to the cricoid. And so we actually like aborted the case, and it was too risky to do a regular trach. And it was kind of like the goals of care discussion with a cric versus just leaving her intubated. We just kind of stopped and left her. But anyways, that would be another indication to do a cric too. So I think you guys are pretty familiar with the indications for trachs. Generally, prolonged ventilator needs can help with pulmonary toilet, or if there's obstruction, like this large fungating mass here on the right. What we see in terms of obstruction can be tumors, can be edema, like angioedema, stenosis here. This is a good picture of subglottic stenosis. So here are the true vocal cords, the white, and then right beneath the cords, you can see like a large shelf of tissue with just this very small airway here.
And the vocal cords are the glottis. So that's what we're, and then the subglottis obviously right beneath it. So obviously we're seeing a lot of subglottic stenosis lately with people being intubated for, you know, COVID and stuff. And so just to sort of orient everyone.
And of course, trauma, like if their entire basically maxilla is totally smashed in, or their mandible is totally smashed, their upper airway, then you might need a trach too. Okay, so generally, what's this guy's name?
Val Kilmer?
Oh, yeah. Some famous person that I don't know. You know, trachs in the wild. We love to see it.
He had head and neck cancer, and so he has a trach now.
So generally we like to, I think I talked about this inside, yeah. We like to do trachs within 7 to 10 days of intubation. There have been various studies that show that that is the kind of ideal time frame to avoid subglottic stenosis, and I'll talk about that in a second. But basically, as soon as people are on a trach, I'm sure many of you have had this experience, you can generally lower their sedation requirements, get them on trach collar, and get them off the vent much quicker, and then of course, better pulmonary toilet. So this is a systematic review. I think it's from 2018 or 19. They defined early tracheostomy as 7 days after intubation, and they identified significantly better results in early trachs versus 14 plus days after intubation, noting reduced hospital-acquired pneumonia, mortality, duration of ventilation, and length of stay in the ICU. I'm not going to go over this, but mechanical ventilation means here, you can see pretty much across every study, much lower in the early tracheostomy, which is this left group, versus the right group. So 20 days, 15 days, 5 days, 29 days, etc. And same for ICU stays, the yellow column here. Okay, we love trachs.
It's our favorite consult to get. We love it. Like, it brings us so much joy to do them. So we have attendings who love it too.
We can do them any day, anytime. Anyways, so what we would like is that there's no expected extubation or attempt to extubate or withdraw care. This is kind of, I don't know, these preferences. We pretty much have attendings that will do trachs on any situation. But ideally, if anticoagulation can be held and if their pressors are stable or minimal, that's ideal. Vent settings too. And then it's important to us if you please talk to the family and make sure that they're aware of the plan before we're like calling for consent and the family's like, what?
Yeah, so that's probably like a big thing. It's just like calling them, having a discussion. We'll go through all the nitty gritty like details with them about, you know, what to expect with the trach, you know, obviously going through a consent with them and like risks and stuff and complications, but as long as there's that initial conversation's been had, then, you know, we're good to go.
This is just for some reference. Basically, an open trach versus a perc trach. We do open trachs only. You make an incision either vertical or horizontal in the skin here, divide the strap muscles. There's some vasculature here that you ligate to prevent bleeding. Divide the muscles here at midline, and then you see your trachea there, and you incise between the second and third rings generally. Perc trachs, like I said, we don't do these. I saw some on SICU service, and I think you guys do some perc trachs, right?
No.
No? Okay. Technically less time, less expensive. You can do it right there at the ICU bedside. You do have to have like someone needs to bronch the patient through the ET tube. But there's a lot of contraindications, which is generally why we don't tend to do them. So if there's thyroid enlargement, any sort of scarring or abnormal neck anatomy, if they're obese, I don't know how you would know if they have calcified tracheal rings until you're there, but, and then of course, non-intubated patients, like you have to put the bronch through the ET tube and you directly visualize basically via Seldinger approach. You put a needle and then a wire into the trachea and you watch it through your scope, and then you dilate up and then place the trach. But we're kind of biased because we only do open trachs, and we have seen many SICU patients with perc trachs have major issues. But in the literature, there really isn't a significant difference in complications. There could be some mucosal and cartilage damage in the percutaneous group, but this hasn't really been identified in humans and patients. This was a cadaver study. But yeah, we think it's safer to directly visualize what you're doing versus just dilate. And then also if a perc trach comes out, basically the entire soft tissue envelope just will close again because you just dilated it. You didn't really like open things up. So it's just, I don't know, don't prefer.
And it's not like other ENTs don't do perk trachs. Like there are other institutions
yeah.
where I know I did an away rotation where they did a lot of perk trachs on ICU patients.
Oh, really?
Yeah. So it just depends, it just sort of depends, but I'd say overwhelmingly, open trachs are what's done by ENTs.
Okay, so post-op chest x-ray, obviously when you intubate someone, you get an x-ray to see where the tube is, et cetera. We used to do this for all trachs too, but now it's kind of just if there's something weird that was going on in the procedure, like if it was emergent, if you felt like you maybe were really low and maybe close to the lungs, suspecting a pneumothorax, there was a false passage, stuff like that. So routinely, we do not recommend chest x-rays. Okay, so this is the most important part to us of this entire talk. Oh man, we didn't bring the trays. Okay. All right, so this is what comes in a box, which we were gonna bring, but I'm bad and forgot. What comes in the trach box. So this is the face plate, which is what sits on the patient's neck. Sometimes it's really gross. Sometimes these numbers are like obscured by crusting and stuff. But this tells you pretty much everything you need to know about this trach. So is there a tube coming out or not? If there's a tube, it's a cuffed trach. It will usually tell you the brand up here, not super important, but we carry Shiley trachs at Loyola mostly.
We also have Bavona too.
Yeah.
Yeah. But we use Shiley, but like if someone comes in with a Bavona,
Yeah,
we'll change it out for that.
And then the top right has the size and the type. So 6 is the size of the trach. DCT stands for cuffed. I don't understand these abbreviations or know where they came from, but it could say CFS, which means cuffless. So if we call it, or if you're calling us and saying like, hey, we have this patient from an outside hospital, we have a trach problem, this is what we want to know right here. What size is it and is it cuffed? So additional stuff, when you open up the box, this is the actual, the tube that goes into the trachea. Here's the balloon with the tubing where you inflate the cuff. This is called the inner cannula, goes right into here, and this should be changed like every day or PRN based on how much secretions and stuff the patient has. This is what prevents like a big mucus plug that could be like fatal. So if there's ever any sort of issue where someone with a trach is having a hard time breathing, you should take this out. And then the obturator is what we always say, like, please keep the obturator with the patient at all times. If you needed to reinsert the trach, you put this in through here, and this kind of like tapered round edge comes out right here and facilitates putting it back in.
Like the stylet.
Yeah,
so
basically, yeah. It's important. I've actually tried, I've tried to put them in without, and it's like, doesn't go in. Okay, so this is your friend in the top right corner. And then there's some other special trachs, which again, all the information that you need to know is going to be written on the faceplate. You don't need to recognize what stuff looks like. You just have to read the words there. So these are called XL trachs. So some of them, if you can tell here, we use these a lot for people with really obese necks. This distance is much longer than the standard distance. So it basically bypasses whatever amount of sub-Q fat they have here to get into the airway. And then it's a normal balloon. So this is called a proximally extended. And it will say on here, actually you can maybe see it here, it says proximal right there, XL, proximal. Meaning the proximal portion of the tube is longer than normal. And then same thing can be distal. And sometimes, like if you guys call and there's a cuff leak and there's something weird going on, we will place a distal tube so that if this area of the trach was dilated by, repeated increasing the cuff, you just get past it. So the distal portion of the tube farthest away from the faceplate is longer than a normal one. And then this is a peds trach, but it's not this population. Oh yeah. So cuff leaks are, happen a lot. We had that a lot in the COVID patients too. But basically what happens most of the time is respiratory or whoever is taking care of the vented patient comes in, checks the cuff pressure. And if there's a leak, they're increasing more and more, putting more air into the balloon. And what happens is that over time, you may not really notice it or think that this is happening, but this area, wherever it's touching the balloon, will just get bigger and bigger. And then at one point, the balloon can't get any bigger. So there's going to be space between the balloon and the tracheal walls. Oftentimes, like basically placing this distal trach is kind of like the last option. So if the patient can tolerate a little bit of a cuff leak, we would prefer that. And of course, the best thing to do is to just prevent that this happens. So don't overinflate the cuff repeatedly. But once we place this distal trach, if the same thing happens down here, we don't have anything else to do anymore. Like there's no other type of trach that could bypass the dilated area.
So yeah,
Anything
I think
else?
we always say like if there's a cuff leak in a patient with a trach, but they're pulling like tidal volumes okay and they're maintaining their sats, then we won't do anything for that patient. Just because a distal really is our last resort, because the last thing you want is to put a distally extended trach in, you're almost touching carina, then you dilate that area, and then it's like, well, what do we have left to troubleshoot for this, you know, if like you now have like a really distal aspect of the trachea dilated. So it can be really frustrating because, you know, the respiratory therapists, the nurses will complain to you and say, well, the alarm's going off, there's a cuff leak, and it's like a certain degree of like a cuff leak will have to be tolerated just because we don't want to use up all the tools that we have, you know.
So if we do trachs, we will put the post-op orders, but basically the important thing is really suctioning, and we prefer to use those soft red rubber suctions instead of those like clear plastic ones that are kind of hard. A fresh trach should be suctioned every hour for at least the first, I'd say 48 hours.
Yeah.
To prevent mucus plugging, which is a major complication of post-op trachs. We usually like that nobody touches or changes the trach until we do it the first time. And then same thing, the inner cannula should pretty much be changed out every shift, especially in a new trach, because fresh trachs make a lot of secretions and that will kind of clog up the inner cannula.
And it may seem straightforward. I mean, the reason why we like the red rubber is just because they're gentler. So like less bleeding, just like less trauma. So that's why we use the red rubbers. And obviously in the event of emergency, well, you know, you can always just page us and we'll come ASAP to see the patient. But like Elycia was saying, so you have the inner cannula, the patient, like you know, you can't pass suction, they're desatting. I mean, just take out the inner cannula because it might just like, I've had that happen so many times where it just plugged the inner cannula and take it out
right
and then
here.
immediately the patient, you know, you can pass suction and everything. So
And you just kind of push in on these little tabs.
yeah, it's just sort of like a
squeeze
pull.
in and then it comes out. Okay, so early complications. So we already went over this, mucus plugs. There's a little mucus plug right there. How you can prevent that is humidified trach collar, or if they're on the vent, humidification, obviously. And then frequent suctioning. Accidental displacement or decannulation. This is why we ask that the nurses don't change the trach ties or really don't touch it at all. And nobody should change it except for us at the beginning. Post-op pulmonary edema. So basically, if somebody is like, can you describe this? Post-op pulmonary, it's like now you relieve how much obstruction they were breathing against. So now when they use the same effort to breathe in, they're pulling like fluid into their lungs. Is that a good way to describe it? I mean, you know what that is. But yeah, so we see this in obese patients who have been chronically breathing against some sort of obstruction there. And like, okay, never mind, not really. And then tracheitis. So this is, I mean, it says complication. It happens. What we usually suggest is 5 days of Cipro. You definitely will know if someone has tracheitis. It smells so bad.
Yeah, it's not just
Very
thick
distinct.
secretions, like it's gross.
Like there's a tracheitis smell.
Yeah.
But 5 days of Cipro, and then if needed, if that doesn't help, we can change the trach out too to get kind of like a biofilm out of there. Okay, so false passage. This is a nice little thing here. So if somebody comes to change the trach and kind of, can you see here, this is the T is the trachea where the rings are, and basically just skived right in front of it and went down. This is the sternum, went down right behind the sternum. Probably this is just the patient probably died from this. Oops. But this is a risk of like replacing a fresh decannulated trach, because this passage, I don't actually can't really see where the tracheal opening is, but this passage from the skin to the trachea is not as formalized yet. So this is kind of one of the risks.
Like you'll see this if you have a patient with a trach and a false passage, it honestly, it won't necessarily look like this where the trach is like flush against the skin. It'll be like popping out. So you like go into a room and the patient's trach like is like sitting out so much further. Like the faceplate is designed to be flush with the skin. And so if it's like a centimeter or so out, like
It's not in.
it's not in the right place, or it could be just like sort of partially, it could be caught up on a ledge or something. So we see it, a lot.
Okay, so if you have difficulty ventilating a patient, like maybe you're alone at night, something's going on, the first thing, like if it's our trach, call right away. We have an in-house resident 24/7. So call right away, somebody will come down. I think anybody can and should remove the inner cannula and suction and see if it was a mucus plug, because that's just the easiest thing that anybody can solve. Okay, check the vent, listen to them. Bring them up for sure to 100% oxygen, and then if you need to, just bag mask them yourself. We'll come and like scope and see what's going on, but basically, if like, let's say a patient just self decannulates, or nursing is turning him to clean him and the trach is totally out. If it's a fresh trach under 5 days, like I said, it's higher risk of false passage if you were to put it in. If it's an older trach, you should try to put it back in. If like, try maybe 2-3 times, obviously while we're coming down, you're the best option at the patient's bedside. So, keep that in mind. But also, it depends on obviously the patient and what the reason that they had the trach, but you can always remember that if something is going wrong, just intubate from above, like it was a regular code respiratory or something. Obviously, if it's a mass or something, you can't do that necessarily, but I would say the majority of patients can be intubated from above. And we think about that too. Like when I go evaluate a trach displacement or something, I think to myself, like, if the worst case scenario, can I intubate this person from above and be fine? And then kind of calm down a little bit in my head. And then some long-term complications. Stenosis can happen even with trachs. That's why we kind of want a little bit of an air leak. You can get granulation tissue from suction, kind of causing continuous mucosal damage, and the trach itself rubbing against the mucosal wall. And then bleeding, we're going to talk about this now. I've never seen this. Actually, I have seen this one time. You seen a TI fistula?
There's someone admitted right now in CVICU.
Oh, wow. So if it's a less than 2-day trach, it's usually bleeding from the skin incision, or like a little vessel wasn't,
or like the thyroid edge or something like that.
Something wasn't cauterized or like totally controlled. If it's over 48 hours, you have to think about a TI fistula, which is a true nightmare. Which is basically, like I mentioned before, there was a patient that had a really high riding innominate and we aborted the case. If the innominate artery here, IA, comes up really high into the patient's neck, like above the clavicles, this trach being in here and moving around and constantly kind of causing mucosal irritation right up against this innominate artery can cause a hole between the tracheal wall and that artery. So then what you have is like basically aorta blood coming out through the airway, because this is right off the aorta. A lot of people will have like a sentinel bleed, which is a relatively high volume, like alarming amount of blood, but then it stops. But then basically, like if this happens and you don't do something immediately, the person is dead. But causes for this, if you make the incision too low in the tracheal wall, approaching where the innominate is, that's a risk factor. Super high cuff pressures, meaning you're pushing the cuff against the tracheal wall and like causing those two surfaces to touch. And then any sort of tube movement. So like if the patient's moving around a lot or whatever. Anything. Very high mortality, 70 to 90%. So what you should do, call whoever did the trach or general surgery or us two people. And then basically I would overinflate the cuff like a lot, hoping that you could tamponade off any sort of fistula that was created. Other options are to like take out the trach or go through the mouth and pass an ET tube below the level of the bleed. So like go really far down, almost like main stemming it and inflate that way so that at least blood doesn't get into their airway. But a little bit more of like a kind of definitive bedside thing would be basically you would remove their trach, put your finger into the hole and like pull the soft tissue against their sternum. Because if you can see here in the picture, this is the vessel that's bleeding and you can push it against the sternum and close that off and stop any sort of bleeding. But obviously what we need to do is take them to the OR and ligate that artery. But this is a bad thing if this happens. Briefly, so voicing after a trach, we get a lot of calls about this. So speech is pretty much like, we're not the boss of this. Speech does this stuff. Passy-Muir valves, this is this purple thing I'm sure you've seen on some people's trachs. It allows air to go in as they breathe, but then when they talk, the air passes by and comes out of their mouth. So it passes by the vocal cords and they can phonate. This should not be used with cuff trachs because they can breathe in, but then, you know, if a cuff is up right here, there's no space for the air to come up through the cords and out their mouth. And it is really important. There's been studies showing rates of depression in people who do not have a speaking valve. So we like to use these unless there's like imminent decannulation, like we did the trach for something that was resolved now and we're gonna decannulate them.
So basically speech is like in charge of like doing this. We don't really have any say, you know, we don't really have much of a role in it. I guess that's the important thing. So when we place a trach and those post-op orders that we put in a speech path consult and you know, they know to see them right away. And speech knows like not to, or to have the cuff deflated or to make sure the patient has a cuffless trach and everything. So
yeah, we defer them.
Mm-hmm.
Okay, also same thing for PO intake. This is only decided by speech. We have basically no, unless we communicate like, please don't feed this patient, we have no role in deciding if the person eats or
Diet
can
per
eat.
speech.
Yeah. Most patients though, with a new trach, they will aspirate when speech does their video swallow tests. So generally it's kind of, once we downsize the trach on post-op day 3, if it's appropriate, that's when it's a lot easier for them to start eating. Yeah. And then decannulation. So we will assess our own trachs that we've done for decannulation, but basically whatever reason that we did the trach, is it over resolved? If they don't need suctioning, we'll tell the patient to put a cap on. So it can be, I think the Passy-Muir counts as,
I think, well, I don't know.
Yeah. Generally we put like another cap that comes in the box. It wasn't in that picture, but it also helps them voice because they're basically breathing through their mouth and nose if it's capped. But if the patient can tolerate 48 hours without needing to remove the cap for suction or to breathe, then we'll take it out. So yeah, any questions about previously placed trachs, we will always come and see the trachs that we have placed. If it's like a general surgery or a thoracic trach, you should always call them first and they can ask us if they need some help.
Okay, so the bulk of our presentation was about trachs. We have a few other topics, and one of them is sort of related to trachs. So just going to briefly touch on laryngectomies. So laryngectomies are different than trachs. They have sort of like a different, different name, totally different anatomy. So A laryngectomy is when what we sort of like broadly said, okay, it's separating the mouth from the lungs. So like when I think about it, so a laryngectomy is we remove the larynx or the voice box. And so now you have two different, there's no longer a common passageway between the digestive tract and the respiratory system or the pharynx, right? So, you know, what I like to think about it is like, okay, they have an opening in their skin, which we call a stoma. That's their airway. Everything else up here is digestive tract. So if you put something in their nose in a person with a laryngectomy, it's going to go into their esophagus. Like there's no connection between the airway from above. And we do this for patients with advanced laryngeal cancer. There's a couple patients I think that we see regularly, mostly at the VA, who've had a laryngectomy because of like chronic aspiration, and so things like that. So like a non-functional larynx.
I was gonna say, I should have looked this up before. There's like some sort of study out there that like 8.9 or something, I'm making this up, it's under 10%, but it's kind of a significant amount. 8% of patients in the hospital in the general, like across the entire United States, have some sort of like laryngectomy or a trach or something, even if they're admitted for reasons outside of being evaluated by an ENT. So this is super important to know.
Nice, yeah. So this is someone with a laryngectomy, and I promise you, they don't always look this like kind of gross.
Fiery.
Yeah, honestly, laryngectomies, so you think of like trachs are like crusting and all that, and like laryngectomies like aren't like that. They're usually, you know, very nice. Yeah. But anyway, so the opening of a laryngectomy is the stoma. So something just sort of like something that we notice a lot, like a lot of people will like say it's a trach. It's not a trach. It's like, it is a stoma. It's a laryngectomy because it's important because someone with a trach has a common, you know, digestive airway connection, whereas someone with a laryngectomy, you know, doesn't. And the tube that you put in someone with a laryngectomy is called a Lary tube. And it's just a clear plastic tube. It's sort of less sophisticated looking than like a trach. Yeah, it's soft. And then the third picture here is someone with an HME cap or a humidification cap. So you obviously still need to humidify the airway. And so this is like a nice convenient way to do it.
So also some older laryngectomies, like people who are 10, 20 years out, or even not that long, they won't wear anything there. They will just keep like the picture on the left. They'll just have their stoma open. Or some people will have like essentially this HME cap, but it's like attached via a sticker that goes over the skin, and they can press on that and vocalize, but that's a little bit out of the scope of this. But so if like it's not bad if you see a patient with a laryngectomy with nothing in there. They don't need anything in there.
They do initially, but then later on they don't. Okay, so the important thing, and when Elycia was saying that there's, you know, a lot of people who come into the hospital with laryngectomies for reasons other than, you know, like head and neck cancer or anything like that. So the important thing is, you know, not to intubate these people through their mouth or through their nose for any reason, because literally you're intubating the, you know, the esophagus when you do that. So you know, oftentimes when we see these patients in the hospital, we'll have the nurses put a sign over the bed that says like patients and neck breather only, like, you know, intubate through stoma only. And a lot of times these patients who will come in with laryngectomies, you'll see they'll get tagged as a difficult airway, but they are the easiest airway ever. You literally have a hole and you take the ET tube and you put it in and you've intubated the patient. So we'll often see that. It's like, well, no, anyone could intubate this patient. So, so it's a very easy airway. And, you know, they obviously need humidification and mucus plugs. So obviously, I think everyone knows that how deadly mucus plugs can be. We talked about it with trach patients, but in laryngectomies, they have one airway, right? You can't intubate them from above. So if they have a mucus plug occluding their airway, then they could die, you know, right away. There's not another option. So you really have to like make sure that they're, you know, keeping things humidified. And the other thing, you know, we talked about suction already, using gentle like red rubber catheters. And the other common misconception is that these patients can aspirate. Now, there is a possibility that there could be like a structural issue, with the trach. There could be, a little, fistula through the posterior wall of the trach, and, there could be a connection with the esophagus that way. But for the most part, these patients don't aspirate because there's no common passage, there's no common pathway for them. So, sometimes we'll see patients that who've had a laryngectomy, and then there's, talking about an aspiration event. It's like these patients don't aspirate because of their anatomy. Obviously, barring, a fistula
Rare
formation,
things.
yeah, rare structural issues. But the nice thing is they don't aspirate. So, okay, so that was like talking about the airway, and that's sort of like the bulk of what we were talking about. So we'll briefly touch on epistaxis. So what are the risk factors? So dryness, like nasal cannula, is definitely a huge like risk factor for epistaxis in the hospital. Well, obviously we already have dry air in the hospital, and then they've got like air rushing through, and it just, if it's not humidified, it just increases their risk of bleeding. Patients with uncontrolled hypertension, they're on anticoagulation. Any trauma. A lot of times with people with facial trauma, they'll almost always say like, oh yeah, I had a nosebleed or something, coagulopathies, patients with septal perforations, like do they use cocaine, do they have Wegener's, things like that. And then usually people with really problematic bleeds, they usually have some sort of underlying condition to account for that. So so there's like this differentiation between anterior and posterior epistaxis. I mean, I think the takeaway is that 90% of it is anterior epistaxis. So it's occurring on the anterior portion of the nasal septum, something called Kisselbeck's plexus, like where all these blood vessels come together. But I think the important thing is that epistaxis can be bad, and I think we all know that. And so it doesn't really, I mean, the differentiate, when you're calling us about epistaxis, don't be like, oh yeah, it's an anterior posterior bleed, like, we just really want to know like severity of it. Like, are they choking on blood, or is it just sort of like dripping out the front of their nose? I mean, we've seen definitely some really bad ones where like it'll like literally seem like their airway is in trouble because like they have so much blood coming up that like down the back of their throat, and they're trying to like maintain their airway. So what do we want, what do we want people to do before they call us about epistaxis? Because it is common. I mean, the air in here is so dry, and they're all on nasal cannula, and they're all sick. So what we want is like, if you guys can order Afrin, it's a nasal decongestant spray that works by constricting blood vessels. Have the nurse spray a bunch of sprays in there. You won't over,
Liberal
like,
sprays.
yeah, like really, get it in there. It's like, they're not gonna overdose on Afrin. And having someone do firm bilateral pressure. Do we expect you guys to put pressure on these patients? Like, no, we don't. Like the nurses, the patient can hold pressure. We'll often tape together tongue depressors and make like a homemade nose clip, and like have, put that on the patient for 15 minutes. And, repeat this, we usually say 3 times, because really Afrin and pressure, like good solid 15-minute pressure, will take care of most nosebleeds.
And no checking.
Yeah.
Don't take the clip off and see if it's like 15 minutes, no checking.
Yeah.
Patients are always like, oh, let me see if it's working.
And then
Let me
like
see if it's working.
blow their nose. Oh my God.
No nose blowing.
So like, and then obviously if there's still an issue, like call us. So we have like a bunch of different things that we'll do. We have silver nitrate sticks, we have packs. If it's really bad, we'll take them to surgery and do, ligation. They can get embolized. These are some of the packs, that we use. The one thing that I will comment, because like getting into the nitty gritty of packs isn't really needed, but we'll sometimes do something called a posterior pack. And that's like when if blood is going down the back of their throat and we want to, tamponade it and like honestly, just like protect it from going into their airway, we'll put like a Foley in, blow up the balloon, and then we put like our regular nasal packing in front. And sometimes, those patients with posterior packs will need like ICU monitoring. They can get that trigeminal cardiac reflex where they have like bradycardia and they can become apneic. And so that's the reason why, that we do that. I think there was a patient in the MICU maybe like a month ago. She got transferred in and she had a posterior pack, and then we took her for surgery the next day. And she was monitored in the ICU, and took her to surgery the next day. And then like ligated her arteries, and then, you know, she came to us on the floor and she did fine. So it's just a precaution. So obviously for epistaxis, it's not just like controlling the initial bleeds. Like we got to figure out, you know, we got to work to take care of the thing that's like sort of like the risk factors and stuff. So good blood pressure control, correcting any coagulopathies, holding anticoagulants if it's safe and things like that. But and then obviously we like really good nasal hygiene. So nasal saline sprays at least, you know, 4 times a day, Vaseline to septum, humidification. A lot of times when Elycia and I were taking consults, we would just like throw these orders in too after we'd seen the patient, just like, you know, so that the nurses, like, you know, could really help with this nasal hygiene.
And also the spray, it kind of is like, well, there's a pack in the nose. The spray should be like sprayed onto the pack. So basically the pack never dries out. The pack, because if it dries out and we remove it, then you're just pulling off, like damaging the mucosa, and you probably cause a bleed again. So that's why we like to say like 4 times a day saline spray over the pack.
All right, so the next thing we'll talk about is invasive fungal sinusitis. So obviously, you know, something really serious, we say it's like pathologies, like number one, like their only real emergency where we'll like call them to come in to read a frozen section. But so risk factors for invasive fungal. So it only happens, you know, in immunocompromised. So that's what we're thinking about. We're thinking about these poorly controlled diabetics, bone marrow transplant patients, other patients with malignancy, patients with AIDS, things like that. So it's sort of like, this is sort of like getting into nitty gritty, but there's a certain pathologic diagnosis where you have to have invasion, and it acts like quickly. It really is very aggressive and has a high mortality. So it's caused by Aspergillus and Mucor. This is like some like nitty gritty information. It's bad though. So it happens in people who are immunocompromised. So it's not these patients who come in with like complaints of like similar to sinusitis, like facial pain and pressure, and they have diabetes and they're on metformin or something like that. Like, no, they're going to be like poorly controlled diabetics and things like that. It's not going to be a healthy like 42-year-old that comes in to the hospital with sinusitis. And they'll complain of fever, facial pain and pressure, headache. The things that sort of differentiated this are sort of like on the bottom there, like they'll have numbness over their face. I mean, they may have these like necrotic areas or areas of necrosis. That's pretty obvious. But like how would you differentiate this if you were like on your ED rotation and from like a regular sinusitis? Well, they'll have all these sort of like sinusitis complaints, but then they may also have numbness and they may also be immunocompromised. So that's when you start thinking, okay, could this be invasive fungal? And it's really rare too. So diagnosis, like physical exam, we usually, we'll usually recommend imaging and stuff, and we'll do a scope and stuff, and that's how we'll figure it out. And we'll take these patients to the OR right away. Like we will pink slip it, meaning like add it on, and it'll be, you know, in the OR within 30 minutes. And this is usually what we'll see like necrosis. This is a nasal endoscopy, like, you know, we'll always have those scopes that we're carrying around. So we'll get imaging. And then obviously treatment. So like we got to reverse that underlying condition. So like tight glycemic control, normalize their acidosis, you know, hold their immunosuppressants if able. I mean, a lot of people die from this. So it's sort of like do or die.
Okay, a couple other things. Mastoid effusions and mastoiditis. Another common thing. So this is more so, I feel like we get called about this like from the ED, but also sometimes on the floor. So just to differentiate, so acute coalescent mastoiditis is like indicating that there's a real infection. They will have tenderness of the mastoid behind the ear. Their ear will probably look proptotic. They're like sick, they're in pain, they're uncomfortable, they have ear complaints. And then you have to have erosion of the bony septations in the mastoid. So see how there's like gaps here versus on this side, it's all nice and solid. You can also have a subperiosteal abscess that you can see here on a scan. It's very rare. I think I've actually only seen it twice.
Yeah, I've only seen two.
But you know, a lot of reports, like radiology reports, will say like mastoid effusion correlate for otomastoiditis. But that's like not like, basically anybody who's in the hospital, they're intubated, they're supine, they had a sinus infection recently. Like I would guess that 10% of the people in here right now would have a mastoid effusion on imaging. It's just not like specific at all for anything.
VA, you'll see it all the time. It'll be
yeah.
like otomastoiditis. And then it's like, that is a clinical like and radiographic diagnosis. I think the neuroradiologists at Loyola are really good about just saying it's an effusion.
Right. So you don't need to consult us if
Yeah.
there's incidental findings and the patient has no like concerns about their ears or pain and the exam is normal. It's just an incidental finding. We don't need to do anything about it. And then the last thing is noisy breathing, personal favorite. So stridor versus stridor. Most of the time, stridor is inspiratory. It can be biphasic or expiratory, but it's essentially caused by narrowing of the upper airway. And I've read something about this. It's like more so the sound of the vibration of rigid tissue versus stridor, which is basically snoring. So like redundant soft tissue moving around. Stridor should likely have an airway evaluation. Stridor, don't call us for snoring. But stridor, you just kind of have to like hear it.
Alicia's being like embarrassed right now. She said she was gonna.
Oh yeah, okay. So stridor is like it sounds alarming. Stridor is like, okay, that's what my dad sounds like when he snores. But if you hear stridor biphasic, usually it's inspiratory, but any sort of stridor you should think about calling.
That was the last thing. Yeah. So just calling ENT consults. So, so our third year, so at night, our call pool is by second and third years. So we're in-house call. And so that's how, we'll do that. But during the day, we do have a consult resident. So it's a third year. So they've already done a year of call. And the fortunate thing is like, so that third year is also part of the head and neck cancer team and like sort of almost specifically assigned to one of our attendings. And he operates, sometimes twice a week and then he's in clinic. So you have like a lot of responsibilities in addition to consult. So, a lot of times the consult resident will be scrubbed into a case. So, a lot of times it'll be the circulator and the OR who will be calling, a consult back. We just ask if you could be, patient with them. We will see emergencies. Like we've both been there where we will scrub out of a case and run to see someone. If you need that, help us triage though. Like if you're calling about epistaxis, say like, I am concerned about this person's airway. They are like blood is coming out of their nose, out of their mouth, not just like sort of like spitting things up or like things like that. So just try to help us like triage. Like if a patient comes in with a trach and everything's fine, it's like, you don't need to like call us for that. But like, if you're concerned, just try to like communicate with us, because obviously a lot of things that we see are on a spectrum of like severity. So we just want to know how serious it is. And that can help us. We'll try to give you a heads up to be like, hey, I'm in a case, like I may not be able to be up there for about an hour and a half or so, or things like that. And then if be prepared to just give us information about what's going on. For if someone's coming in with a trach, we literally just want to know the size and then if it's cuffed or not. Because what we have to do is like, not all trachs are in all parts of the hospital. We wish they were, but they're not. We have like one really centralized location of where trachs are in the hospital. And we want to bring us the same size. We want to bring a smaller one because like, what if we can't get, what if there's an issue? So that's just like why we're such sticklers about like knowing trach sizes and stuff. And then tell us what your preliminary exam is like, honestly, I mean, looking in someone's ear, I appreciate that so much. It's like if someone's calling about like ear pain, it's like, we're all going to ask like, okay, well, what did you see on, even if you're like, I looked, but honestly, I'm not sure, like what I'm looking at, like, we appreciate that. So, So yeah, just let us know if you have any questions. This is our pumpkin from last year. But yeah. Sorry for the technical issues or if we went over 1 o'clock.
Nope, no questions. Ooh, yeah.
Oh
with
yeah,
our
tag
pumpkin.
us. Like that. What's this like? No.
Oh,
I'll take it, guys.
no problem. Nope, at least when I was,
So one of the Wi-Fi's. There's